So I'd like to enlist everyone's help in this talk because this is an area that is actually only available in a few centers, and I don't have really personal experience with it. We do have a physical therapist here who has some experience, and I'd really like parents' input on this. So what I've done basically is, again, through my background as a physical therapist, almost 25 years ago, learned about electrical stimulation of muscle. And that was really different then. We didn't even have laptop computers and things like that at that point. And the electrode systems that we had were much simpler and bulkier. So there's been a lot of evolution over the last 25 years in this kind of technology. Surprisingly not as far as you would think. Because we've all seen the bionic man, the bionic woman, and we know that these things are possible. But it just hasn't been an area that has developed as much as I would like to see. So with that, there are many different types of electrical stimulation. This includes motor or muscle stimulation, and the main one I'm going to focus on today is neuromuscular electrical stimulation, and that's for neurorehabilitation. There are other areas, though. Many of you may be familiar with the sensory systems, the TENS units, which are applied to the skin, and they're to interrupt pain. Also, other things. When I trained in PT, we used it to apply medications through the skin, called iontophoresis. We use electrical stimulation of the vagus nerve in epilepsy, and that has actually been very helpful to a selected few patients. And then now we're even using it in the brain for thalamic stimulation for movement disorders like Parkinson's disease. So there's been quite a lot of advance in how to get electrical stimulation into the body, into the brain, even into the spinal cord. Muscle-wise, there's two main types. There's therapeutic, and I'm going to talk just one slide about therapeutic electrical stimulation, and then what's called functional electrical stimulation, which is really the rehab kind of electrical stimulation. That can be applied through the skin or transcutaneously. That can be applied directly into the muscle with muscle electrodes. And then epidurally, this can be applied over the spinal cord. They can also use this rather than just to elicit a muscle contraction. It can be used to give feedback where your limbs are in space, a function called proprioception. So this is not muscle exactly, but it's to give feedback so that the muscle knows what it's doing. The main purposes would be for standing function and ambulation. So those are sort of two major things that have been looked at. And then other things have been considered. For example, what is the effect of this kind of electrical muscle stimulation on bone density? Can you improve the bone density so that you don't have as high a risk of fractures? And what about sphincter control? This has been looked at both in bladder and in anal sphincter control. Could you really help someone determine when it's time to pee, to empty that bladder? So the first type is called threshold or therapeutic electrical stimulation. And this is a very, very controversial subject. What this is stimulation that's applied below the amount that causes a muscle contraction. So it's not a functional use. It's not something that causes you to move your limb in space. It's more an idea that if you chronically stimulate these muscles, that you'll actually get some benefit. But in just last month's Developmental Medicine and Neurology journal, they had studied 47 children with cerebral palsy. And as you'll notice in this talk, there's not a single study that has anything to do with TM. So almost all of these are going to be based on other forms of spasticity, or most of them are spinal cord injured patients. So this was 47 children aged 5 to 18 years, and they did a 1-year placebo-controlled study where they had 2/3 on active muscle stimulation and 1/3 on placebo. They studied these, I think, nicely by videotaping the testing procedures, and they had them blinded so that as best you can do, I think it was a good study. They also used muscle CAT scans to look at the muscle bulk to see if there was any difference. They found no significant difference between the active treatment group and the placebo treatment group. So I think that at this point, there's no evidence to say that this type of muscle stimulation is truly beneficial. However, you know, there are maybe potential to further study that. More has been done in the field of neuromuscular electrical stimulation, or the functional, the one that moves the muscle. It causes a contraction in the muscle sufficient to cause a joint movement. This has actually been available for more than 40 years. It's been used to prevent disuse atrophy. That's something that when you sit in a wheelchair or you have weakness, paralysis of one arm, or wherever the muscle weakness is, if you don't use it normally, you don't have the normal stresses on the bone, and you don't have the normal input to that muscle to keep it well. And so you wind up having something called atrophy, or loss of muscle bulk. Also, it's been looked at to enhance effects of exercise after some sort of neurological injury, and then to improve function overall in neuromuscular disabilities. So again, this type is called functional. It causes a contraction of the muscle sufficient to move the joint. You stimulate the muscle itself or the nerve with this kind of electrical stimulation. And possibly the spinal cord. So that's of great interest to this group. So it could be done through the skin, transcutaneously, be done within the muscle itself, intramuscular, or it can be applied over the spinal cord, which is called epidural. Other uses, I think I already mentioned. You could maybe use this to stimulate bladder contraction, so you could have emptying of the bladder or relaxation of the bladder sphincters. You might be able to also allow bowel control by changing the tone of the anal sphincter. Increase bone density. There's even a study on blood pressure control in a high quadriplegic patient from a spinal cord injury. And in that same patient, they also studied augmentation of the cough. And this is a high cord injury which affected the diaphragmatic nerve C3 through 5, so quite high. Okay, so where would you put this? If you could put electrical stimulation in your kid's body, what would you want? So areas that you might consider would be hip flexion here. If you don't have normal innervation, you're not going to be able to lift your knee up when you're walking. Another big area here is the quadriceps, or the knee extensor area, because as you walk, you want to get a swing through. You want to be able to get that foot out in front of you. And then after that, or at the same time, you want activation of the muscles that pick up the toes here, or the dorsiflexor. So all of you are pretty familiar with that, right? Those are hot spots, areas that you might want more power. So this was a study by electrical engineers. And what they did in this study is they took 10 healthy 10 subjects, and then 5 controls. So they had 10 that they applied the therapy to, and 5 controls. And these were all healthy male subjects. None of them were injured in any way. They gave stimulation of 45 to 60 hertz, and that's the frequency. 12-second stimulation, 8 seconds of recovery, for a total of 30 minutes per day, 3 days per week for 6 weeks. So this is actually a fairly typical protocol. And you can, not necessarily the durations and the frequency, but 3 times a week for about half an hour, I think is fairly typical. So believe it or not, they actually got biopsies of these healthy volunteers. The VL stands for vastus lateralis. It's one of the large muscles in the quadriceps, the one on the outside. They did it before this stimulation procedure, and they did it after the stimulation procedure. I don't know how much they paid these guys. What they found is that this kind of stimulation actually did change the histology or the cellular characteristics of the muscle. I didn't want to go into details about what type. It was the heavy myosin fibers, and it changed the subtypes. Others, some increased and some decreased, but overall they felt that it did increase, based on these muscle stains, they did feel that it increased the oxidative capacity. So how it handles carbohydrates and how it sort of produces energy for the muscle. It wasn't very dramatic though. What it didn't alter was how well these subjects performed aerobically, and it also didn't change the EMG. That's the electromyograph, where they put the needle into the muscle and look at the characteristics of it. So that was a little disappointing, but still there were some promising signs that it was changing something. Then from the American Journal of PM&R, they did another study where they used this little computer. This was developed by a guy named Yamamoto, and remember that 25 years ago, this would have probably been the size of this room. So that's a really advance, I think, in the technology. So this is something that is not necessarily portable, but at least you can use it in a research setting, and you could use it perhaps in a therapeutic setting, but maybe not necessarily at home. So this has the microcomputer controls and a waveform generator and an amplifier. So that's this section. And then over here, you have any of you, have your children been on a KenCom? A KenCom is a device that you can set up to do different measurements of muscle function, strength, and torque, and things like that. So it's a fairly standard tool that's used in research of this kind. So you can measure muscle force with this. And in this study, what they did is they took 6 healthy young men. They applied currents of less than 10 milliamps and voltages of less than 80. They applied electrodes over the rectus femoris muscle. That's the big one in the middle. The vastus lateralis, the one on the outside, vastus medialis, and then the adductor longus. That's the one that brings your knee in toward your other knee. So those are all important muscles. On this study, actually, they did an MRI scan. They looked at baseline, and then they exercised the patient. So they gave them a 30-minute rest period because they wanted to make sure the muscle was rested when they imaged it. Then they did a little exercise protocol, and within 7 minutes of the exercise protocol, they did another MRI scan. And they looked at differences between those that were stimulated and then those that were not stimulated. And this actually doesn't show the results, but it shows you what the muscle MRI looks like. And it's a very poor quality reproduction here. But in MRI, this is the section through the thigh muscles. So it's like in the brain and the cord, you see sections. This is a section through the muscle. This is the bone. And you can see various muscles here. You can actually identify which one is the rectus femoris. This arrow is a little bit off. It's really this muscle. You can see the vastus lateralis muscle and the vastus medialis muscle. So what they found is that there was a quantifiable difference after the electrical stimulation to these muscles compared to before and after the stimulation. And really these changes probably have to do with water content. When you exercise your muscle, it gets a little bit more water content. But at least it was a way that was non-invasive. They didn't have to go and biopsy these muscles to tell if there was any difference. So they probably had a lot more volunteers. So it was promising in that this is a nice way to actually look to see. And you could see that there was an effect of the stimulation on the muscle. Okay, so this is a study by Myelitis, and again, these are all very current. Most of these have been published in this year. This one was called electromyostimulation training, and they did a high-frequency input to the muscle, strengthened healthy human skeletal muscles. So these aren't impaired subjects at all. They were trying to figure out whether this was really an effect on the muscle itself or whether it was coming through the nerve, because that makes a difference in sort of how you conceptualize how to use these treatments. So they used 8 healthy males. Also, you'll notice that although most of these are male subjects, and that none of them are children. So they gave a 4-week electromyostimulation. They tested them before and after, and these were 16 18-minute sessions. And what they found is that the plantar flexion, the ones that push toes down, gives you the power to push off when you're walking, did not change. But there was an increase in strength. So the contractile properties didn't change, but there was a slight increase in strength. And they noticed that after the stimulation, there was a little bit more EMG activity in the agonist muscle, the one that pushes off. And they noticed that, in addition, when they pushed off, they didn't notice a change in the antagonist. And I'm going to show you an illustration of that. But there was enhanced maximal voluntary contraction. So the power was just a little bit better after the stimulation period. So this is an illustration of the plantar flexor muscle group here, the one that pushes the toe down, that's a really important power muscle for ambulation. And this then, the muscle group that does that is the plantar flexor group, the agonist group, and then the antagonist would be the ones in front, or the dorsiflexors. So they noticed increased power here, no change here in the antagonist. So really one of the questions they were asking here was, how is this working? And they couldn't figure that out directly from the study, but they did think about possibilities. So yesterday we talked about how there's the upper motor neuron and then the lower motor neuron that comes from the spinal cord out to the muscle, and how when you have transverse myelitis, you have an effect on the upper motor neuron, sometimes the lower motor neuron, but mostly the upper motor neuron, and how there's a lot of input that's missing then. You have lack of inhibition. You have lack of relaxation now to the muscles that go out, so you have spasticity. And also weakness, which we also talked about yesterday. So what they thought in this study was that probably the effect was actually from up here, the supraspinal, above the spinal centers, that were having an impact here on what was going on down here at the motor neuron, the lower motor neuron. Okay, and now these are all transcutaneous studies that I've presented so far, this one as well. So this one was from the Journal of Neurophysiology. And what they were looking at in this study was, how do you stimulate the muscle? Is there a formula that works better? And so they looked at the thenar muscle. And the thenar muscle is this muscle, big muscle group here in the thumb. And most of your kids with TM don't have upper extremity problems, but some of them do. So this was just a way to look at it. So they took 6 healthy subjects and 6 subjects with spinal cord injury. And these were fairly high, affecting C5 and C6. So those are the fibers that give your arm strength. And they found that it's a little complicated for me to explain this because I don't really understand it very well, but they give a train of stimulations. They give a series of stimulations, and they found that if they gave 2 at the very beginning, or what's called a doublet, they got an increase in power and then a second increase in power. So that worked pretty well to give this doublet at the very beginning. And they found that the continued train of 7 pulses was the thing that resulted in the maximum voluntary or involuntary contraction. And so they compared that in paralyzed subjects and then in the non-paralyzed subjects. And they found that this train of 7 increased the strength or the force more in paralyzed subjects than in the non-paralyzed subjects. And it was actually pretty effective. Okay, so there's a lot of evidence that this even transcutaneous muscle stimulation is having an effect, but whether it actually can increase your overall function is less clear. Now this one, they looked at bone density. They were curious, if you stimulate this muscle, we know that the muscle force is what causes the bone to form and stay strong in certain areas. So they looked at 12 healthy spinal cord injured males, in the males. These males were more than 2 years from the time of their accidents. And they had Ashworth scales, remember the spasticity grading scale yesterday, of 2 to 4. So they had significant spasticity. And they did 3 training phases. The first 2 are presented here. The first was just a quadriceps, the big 4-muscle group here in your thigh that extends your knee, brings your toes up. That was strengthened in a baseline portion. And they did a bicycle where they applied the electrodes here to cause a bicycling movement. And they built up to 5 to 30 minutes of exercise in these guys. And what they found was that when they compared the baseline bone densities of the spinal cord injured men to the non-spinal cord injured men, there was a decreased bone density of 70, with spinal cord injured subjects having 71 to 82% of normal. And that was at the hip, and the lumbar spine, the vertebrae, were actually the same. So the spinal cord injured subjects had not demineralized their spinal cord, their spinal column. But it was interesting when they did the DEXA scans, because after this functional electrical stimulation, they found an increase in the one that wasn't different from normal. They found an increase in mineralization of the lumbar spinal column, but not in the hip. Now the problem with this is that the hip is the one that gets broken in most cases. So the risk of fractures is much higher when you have that problem. But they were looking at, this is a potential way to treat bone density. And I think there may be better ways to treat that, but they did show some back. So from this surface stimulation, what are the advantages of it? Well, you can directly stimulate the muscles in muscles that are not otherwise active in a spinal cord injured person, or in transverse myelitis. You could sort of make that leap. It also worked in muscles that were abnormally activated. In other words, maybe in some muscles that were spastic, or in muscles that had absolutely abnormal responses. So when they were stimulated, maybe they would go into a spasm. So it was actually effective, not necessarily in a functional way. The disadvantages were that the system, as I showed you, was very complex. You had to have the laptop, and then you had to have these electrodes. The size of the stimulator, I didn't show you a picture of this, but some of the stimulators, they actually are fairly large. So you have to go through the process of applying these 3 times a week. There could be problems with the skin being irritated from all these electrodes. You see some yeses in the audience, yeah. And you have to use a lot of these electrodes to get any kind of a functional movement. You have to apply them to the quadriceps, you have to apply them to the dorsiflexors, even the gluteal muscles or the hip flexors. So there's a lot of these electrodes on. If one of the studies did adults with stroke, and they found that when patients were being asked to try to apply their own electrodes, if they didn't have one, if they had weakness or spasticity in their arm, then they actually couldn't manually apply them very well. So that was a problem. And in some of our TM kids, they have one arm or both arms that are weak, so you need help. And then it would be difficult to set this up at present as a home program. But if you had a home program, you could apply it much more frequently, and you could sort of customize it. And you can only get to the muscles that are on the surface. So you can't get to deep muscles with the transcutaneous or the surface ones. So now, this is a couple of studies where they actually did intramuscular. I don't know, they didn't go into great detail in these studies about how they took care of the skin, but these were implanted electrodes, and they tended to be tunneled and come out at one place, but then you had electrodes kind of hanging out of the limb. So they looked at 4 paraplegic subjects with spinal cord injury. They implanted these intramuscular electrodes in the vastus lateralis, big muscle on the outside, and the vastus medialis, which is the big muscle on the inside, for knee extension. So this was just a study where they were just trying to get that one action. And the goal of this study was to allow someone to stand up so they could, work at their homework, or they could help in the kitchen or whatever functional thing they wanted to do. And then for 3/4 of the subjects, they found that this kind of stimulation was adequate to allow them to stand, and they could also rise from a chair. That's a really important function. If you can at least, get up and then be up for transverse, then your function could actually improve quite a lot. So here are the muscles. This is actually the rectus femoris muscle. What's unique about this muscle is that it crosses 2 joints. So it comes above the hip and it attaches below the knee. So that's kind of a tricky muscle. The vastus medialis is this big one here on the inside, and the vastus lateralis here. So these were the ones that they applied the intramuscular electrodes to. So I think that there was evidence on that study that you could actually improve function, but you had to use, at that point, an intramuscular electrode. Now, what about the spinal cord? So they have a model of what's called a spinalized frog. And in this model, they've been able to use the frog to record what's happening at the ankle and other sort of movement patterns that you can elicit by stimulating over the spinal cord. And so they have found that you can stimulate at various locations on the spinal cord in an animal. I think they've done this in rats as well, and shown that you could sort of design a pattern of movement that simulates ambulation, depending on where you stimulate. So this was a human study, 13 subjects, and I think these were spinal cord injury subjects. I didn't say it on here. They stimulated the dorsal lumbar cord structures, and they tested them with EMG. So they put an EMG on the muscle, and recorded what happened as they stimulated over the spinal cord. And what they found was in the upper lumbar cord, the upper part of the low back, they could stimulate the quadriceps, the big muscles here, and they could stimulate the adductors, so the ones on the inside that bring your knees together. They found that in the lower lumbar region, they could stimulate the tibialis anterior, that's your dorsiflexion unit, picks your toe up when you're walking, and the plantar flexor root. So both of those, depending on how they stimulated, you're kind of moving this device up and down over the spinal cord. You could, actually not moving it, but using different sections of the stimulator to get different effects. And with this study, they felt that what they were stimulating was not really the cord itself, but the roots that come out, okay? So there was some evidence, again, that you could make the system work by stimulating over the spinal cord. Now this one, I think we're going to have a talk. I thought it was Dr. Pidcock, but it's another doctor who's going to talk about partial weight bearing therapies. How many of your kids are involved in any kind of a partial weight bearing ambulation program? 1, 2, 3, 4. So, okay, so a number of kids. So what they did is they combined this epidural spinal cord stimulation with the partial weight bearing therapy. And they found that they could improve what's called stereotypic, meaning a pattern that happens the same every time you do it. Stereotypic stepping patterns. And that spasticity, which inhibits a lot of motor function, was actually reduced when they used the spinal cord stimulator. But they also found that there was insufficient safety, that there was energy cost, it was difficult, and it was fatigue, caused a lot of fatigue, so they kind of looked at that. They did find that there was an immediate improvement in gait rhythm, so it looked better, it looked more like a normal gait pattern. And in this study, when they looked at a 15-meter segment of gait, there was almost no difference between those that were stimulated and those that weren't. But over longer distances, they felt that it actually was helpful, that they could be more functional in the home and community. But again, remember, this is only 13. Okay, and in this one, a lot of these studies were done at VAs. So we have to really thank our veterans for participating in these studies. But This was a retrospective study, meaning that looking back at the past and looking at long-term efficacy. These were 17 spinal cord injured patients that had the epidural spinal cord stimulators. They had a total of 24 implants, so that a number of these patients had had a re-implantation of their stimulator. The total cost for these stimulators was more than $500,000. And of these 17 patients, only one patient experienced relief of their spasticity, and that was what their parameter was. And they found then that it was not cost effective. This is a study of 17 patients, so very small. Okay, so we talked about what happens to the muscle. So imagine now that you've got your bionic arm and you can pick something up, and but you don't know how much contraction to give. So you can stimulate, but you crush the paper cup. So what this study was looking at was, can you give feedback somehow to tell the person how much contraction they're getting? So they did a series of feedback on the shoulder. They had a little pattern, and the pattern would tell the person exactly how much force they were generating with the muscle stimulator. And they did find some improvement. They found that it could improve the feedback. The patient understood better what their limb was doing in space. So that's really important for hand function, but it's also important for gait. You have to have some kind of feedback mechanism, or you have to watch yourself walk all the time. And that's not very functional. Anal sphincter. This is a big one. I can tell from the comments yesterday, bowel and bladder function are huge issues. They looked at 5 healthy spinal cord injured patients. They put a small pressure recording balloon into the rectum to record the pressures, and they used a battery-powered stimulator. So this didn't sound particularly bulky. This sounded like a pretty small system. And they found that 4 out of the 5 patients could have strong anal contractions, so that they could detect that. But the problem was it didn't change the total pressure that was recorded. So they could get the contraction, but the contraction wasn't functional. All right, so my conclusions here are that therapeutic electrical stimulation, the one that doesn't cause muscle contraction sufficient to move a joint, has not been proven to be efficacious. So the TES is probably not going to be where we should put our money, although perhaps more studies need to be done. Neuromuscular electrical stimulation, or functional electrical stimulation causing joint movement, has promising results. And I think I've shown you some studies, a lot of different studies that have shown improvement in strength in some of them and improvement in gait in some of them. But the way that we stimulate the muscle itself, there's probably a lot of room to look at that. Do we give the doublet and then the train of 7? Are there even better ways to do it? And then, because it's not practical to use intramuscular, or in many cases it's very expensive and maybe not practical yet for epidural, the transcutaneous method we need to refine. We need to get it so that it's mobile, so the person can have it with them, and probably self-programmable. So again, there's potential on the epidural electrical stimulation. Maybe we can improve gait patterns if we can also make that a little bit less expensive, but it's still going to be very invasive. We haven't got any studies on children that I could find in the literature. Now, I think there's anecdotal reports and there are people that have actually published on this, but they're not studies that are large. Another thing that popped out of the literature is that if you apply these methods before the loss of muscle bulk and before the loss of bone density, it's possible that you're going to get a better result. So shortly after the diagnosis of TM or spinal cord injury, maybe that's a better time to apply these before you're trying to rebuild a system that's already partially lost. So I think, you want to make some comments about it from what your practical experience has been? There's a lot of this around the Chicago area.
There's a lot of therapists that will use your functional stim and a TES. I mean, it just depends on where you go. because there's a lot of studies on it, it's been difficult to come up with some protocols. Now, I have used it. What you were talking about was using for ambulation, and when you use stimulation for ambulation, most of there's Shriners Hospital in Philadelphia is the one place I know that has some studies on children ages 5 to 12. Now, there's some issues and problems with kids and stim. The electrodes that you sew into the muscles kind of pass the sensory system, so for your buck that doesn't hurt. The amount of stimulation you have to use is quite a bit to get these kids up. Now, I will tell you just from using electrical stim with kids, muscles have 5 grades, 0 to 5. And in order to get the limb to work against gravity, it's got to be at least a 3+, 5 meaning most they can do. From what I use, I only get the kids to maybe a 2+. I can only use the surface electrodes because I don't have the machines or the surgical implants. And most kids don't tolerate more than that. There hasn't been anybody, again, I don't have them on 8 different parts. The most I've been able to do, because my machines are small, are 2 at a time. There are places in the United States that have machines, ox-stims, that can do 4 muscles at a time. And they are trying to do some things on more like a computer program that are surface electrodes. But the problem with the kids with TM is that not all kids with children that don't have sensation lower in your T levels and your complete spinal cords, they tolerate it because they don't necessarily feel it. They can tolerate the fair plus and more contraction that it needs long over time so they can walk with it. The kids that have some sensation, they don't tolerate the surface electrodes, not high enough to walk with. What you can do, if with TM, they were talking about upper motor neuron and spinal cord being the area that has been damaged, but with some kids, their peripheral nervous system, the nerves that go into your legs and to your arms, isn't damaged all the time. And so we can put electrodes on those muscles, and if you and stimulate sometime and get some nice changes. I'm not talking about big changes, I'm talking about little changes. There's been some studies on children with spina bifida which don't have a spinal cord, all of them don't have a spinal cord cut, some of them have lower motor neurons, but there's some connection. If they're innervated and they have nerves at work, the changes have been a half a grade in a manual muscle test. So that's at least some way of measuring. It's not like you just do it and do it because we're trying. I have done it with some kids with TM. I can say that the bigger muscles like the quadriceps, I can get pretty good contraction. Now, can they use it more functionally? Sometimes the kids with TM are using spasticity to do some of their walking. So that's why I kind of like chose the quad to see if I could get more active control. But that muscle alone isn't going to always make your walking better. So if they have the muscle, I've been able to try to make more fibers contract. It's like a 50-50 deal. I haven't, if they show me that they have a little bit of voluntary control in some of their lower leg, a little bit of toe extension, not spasticity, I've tried to get your stabilizer muscles, your abductors, hard to do, very hard to do. The hip flexors, which are your muscles that kind of help propel your gait, are too deep to get with surface electrodes, just too deep. Because you can't, I know kind of where I'm putting them, but I'm not inside, and muscles overlap each other. Some are deeper. So there are some muscles that are just very difficult to get, especially in your forefoot ankle. So as much as we try, it's still an art, not a science yet.
So I think what it all boils down to is that there's a lot of promise behind this kind of technology, but it's not at the point where it's practical for people to, okay, here's your system, you're going to walk out of here with it. It's still, ways off. But I think that the research should be supported, and I think that it should continue because maybe years off before we get other therapies as well. We want to make sure that our kids have mobility and strength and grow up with as much function as they possibly can.
Can we hear from people what they've tried and what works and what doesn't? We did electrical stim when Danielle was about 2.5 years old. She did have some pain reflex from it. That's the only time she ever really experienced pain. We only did it maybe 6 times and quit.
Where was
Because
it
she
applied?
cried.
These were transcutaneous, these were patches that were
Yes,
applied.
patches on the skin.
And
She
the
was
legs.
about 2.5 years old. But she cried every time that it was done, so we quit doing it.
Joe?
Well, Cody's had hers portable unit a little bit, less known, that you guys have seen, and she's had a lot of great results for but they're more like what would affect a teenager, or it's more of a vein thing. She didn't like having a flat butt, so she'll do her homework, she'll put her patches on, and you'll walk in her room and her little butt muscles are flexing, and she's and
It's more for contour.
it's more for contour.
Here's a motivator.
She figured out how to do that on her own, and then she does it in the standard with her therapist to try, and it's helped with her blood flow and all that. But then she's had some problems recently, all of a sudden, out of nowhere, with the skin. And we don't know if it was a new type of patch or they changed something, so we're looking into that. But I wish I would have known. I don't know, you're going to probably say it wouldn't have changed things, but I think for looks-wise, she started to get scoliosis because when she got TM, she went through a real change in her spine. And I think the E-stim, had I known where to put it on her back, might have helped pull some of those muscles back around that were being affected.
Is she still doing it to her back?
Amy tries to do it to her back, but we still haven't figured out quite which, are we really doing any good with it? But I think had we have done it earlier.
This was our recommendation for those of you who don't know. When we saw Cody, she had a little scoliosis, which many of the kids do, and it's really due to asymmetric pulling in that it's an incomplete lesion partway on the back, and so there's a little bit more pulling on one side than the other. So our goal was to use the stim actually to strengthen the opposite side and kind of pull back into a balance.
But you've got to stay with it. That's the thing. And Cody's very disciplined on the stuff she does. But then we haven't had the therapy as often on the back. But I think if a lot of the parents with younger kids got into it, but it's just
I think with scoliosis as well, there's a real rotational component.
Yes.
And those are very small, somewhat deeper muscles that cause the rotation. So it's going to be very difficult, I think, to show how many kids with TM are we going to be able to do this kind of study on, and how are we going to get to the deep muscles with the surface.
And I think that's the one. But she's had a lot of luck with surface stuff.
Our son has had a lot of functional stim done in his hands, and we've had great results. I mean, once we started it on his right hand, he really improved his function, and then we kind of focused. We got his right hand up to, I'd say, like 85% or whatever, but really it's very functional at this point. And then we moved to the left hand, and the results haven't been as good, but we are still getting results. And that was, we started the left hand, it was probably close to like 22 months after. So we didn't even work on the left hand, and we're now getting some thumb movement. And it's a small improvement, but with his walker now, he can do this. I can say, use your thumb, and he flips his thumb over the walker, and we can grab it now, and he's improved his strength in his hand. So,
And the hand muscles are very tiny little muscles, so you can apply sufficient to, if it's tolerated by the child, you can apply sufficient to actually, it's not a heavy limb that you're trying to
I think that's it. They're small muscles, and he's definitely improved strength in his hand. So, I mean, I don't know that it created any new neurons, but it certainly strengthens what he had, and functionally it's made a big difference.
And it's not been painful?
It seems like his sensitivity at times is higher than other times, so they gauge it by him. I mean, if he's more sensitive, they lower it. And sometimes he's like, no electrodes, but we put him on it. We've been able to get past it. He tolerates it pretty, I would say, very well, really.
You combining active exercise when he has them on?
Yes, we're doing things at the same time.
But are you are you just cycling the machine, or are you like zapping them,
No, but whatever.
It's just cycling,
It's cycling.
like on
But
20
it's
off.
while he's functionally using
Okay,
position.
yeah.
That
That
time
makes
the
a
partial
difference.
weight bearing
Yeah.
study that I presented, I think, it seems to enhance an exercise program. There was another
Yeah.
question, yeah.
I just wondered, does the E-stim, does it evoke a direct action potential on the muscle, or does it promote like vesicular release like acetylcholine? That's one question I got to follow up.
Yeah, from my understanding, it looks like it's probably working possibly on the nerve, because the timing of the changes that they can detect in the muscle probably isn't a direct muscle effect. So, the theory is at least that it could be working through the peripheral nerve, or it could be working even from higher centers, even though that's not what's being stimulated.
Okay, and are you aware of any studies that have looked at E-stim combined with some sort of, and this might be a little scary, pharmacologically, inducing, the release of certain neurotransmitters at the same time, try to get the
You mean like
deeper,
nicotine or something like that?
something like that. Is there anything like
I
that?
haven't seen anything.
In
Anyone
rats?
else aware?
It's a good idea, but I haven't seen it.
Yeah.
We noticed with our son doing the electrical stim, from him being laying down on the floor, he couldn't get into a sitting position on his own. After about 3 weeks of doing the electrical stim on his back, his butt, and his quads, he could get himself into a sitting position. He's not hands-free, but he could do it in a much quicker time. We take Cole to Blue Ruby Macmillan Center in Toronto, and it's all for spina bifida pretty much.
But Canada has actually done a lot of pioneering work.
Yeah, and they say it makes children, they think, it makes children more aware of their bowels, and so we do it, on his butt.
That's a
as well.
really important functional improvement.
We have the stimulator with us if anybody would like to see
Oh,
it.
really? I'd like to see it. So does he have a six-pack or?
Not yet, we're working on that.
But it's applied to where for Cole?
Well, we do it
We put it
everywhere.
everywhere. Anywhere that we can get a movement, we make a move.
He gets his dorsiflexors, and we do it, his legs, his butt, his back.
Does he like it?
He doesn't mind it. As long as he can get around, we have to
And
follow him around
we
with the
can
wires.
You
so.
can control the power, how much you want, and it's all like little numbers. And you can tell as soon as you get a movement, that's where we stop. Like we don't get it so it goes bang, blows his arm off.
Out of your day to do this?
It's
It's
about
hard.
45 minutes every 2 days. We don't do it every day.
No skin problems yet.
No, we do.
Sometimes there's allergies.
If we do this area one day, we won't do it the next time. We'll do like rotate, so you're not always getting the same spot.
Yeah. Great comments, yeah.
Brainstorming here, but it would seem to me that the pain would be in proportion to the size of the electrodes. The amount of surface area that you're concentrating the input in would affect more pain fibers. In addition to that, anything of combining pens with the stimulation in an effort to try to somehow control the pain simultaneously with the delivery of the impulse.
I don't know, I haven't seen that. You know,
I just heard the last half of the question.
if they've used a sensory pain decreasing PENS type unit with the electrical stimulation.
It's usually one or the other as opposed to either.
The only thing I saw was that you have to sort of search for the motor point. And so if you can apply the stimulation over the motor point, that particular area of the muscle that's most sensitive to it, you can get more bang for your buck.
Just swallow electrodes.
Well, the best tolerated ones, I think, you guys can help me on this, are the bigger ones.
It's just the opposite.
Yeah.
The bigger the area, the less it bothers the kids. Kids tolerate it differently than adults. They really do. And as much as you try to find a motor point where it should be, in kids it's not always there.
Yeah.
So sometimes you need to use, if you're doing the upper extremity, the muscles are smaller, you got to use a smaller electrode, because if you use too big electrode, then you're going to get a lot of recruitment and do like more muscles than you want to. Sometimes that's a good thing, because when you're doing wrist extension things, you want more. More is better. Sometimes more isn't better. So it just depends on what you want to do with it. I too think that doing it in a functional position, I've done it to the back, hasn't been on kids with spinal cord injury, has been on kids with cerebral palsy, and I wish there could be more scientific. Sometimes what you can do is, you don't always necessarily get the real deep paravertebral muscles. Sometimes you get some other things, but where I see the bend, and like you're trying to do the other side, so am I. I go above and below the crook, sometimes with the long 2-inch electrodes, sometimes with the skinny long ones. And you'd be amazed that at least cosmetically, I didn't have EMGs to see what I was really stimulating, okay? But cosmetically, you do get more alignment when they're sitting. And so you do homework, we do piano or whatever, but that might be helpful, and that's what you were trying. Big electrodes though, not little.
My wife went to get our machine, so she's gonna, you can see the size we
Yeah, that's
use.
great.
That would be
Actually, you were talking about the Douglas stimulation. I can see that somebody has looked at the normal pattern of stimulation in the people body, and like doing a whole thermometer, they've looked at these patterns and computerized to find out what the common denominators are in these polynormal muscle stimulation. So,
I don't know that you I don't know that you can actually detect what's being generated at the motor neuron.
well, the EMG tells you what.
It doesn't tell you though what's happening at the cellular level and what those stimulation frequencies are.
The EMG is a CMAP, I mean,
It takes a sort of the big compound.
big compound muscle axis, so it's a summation. But
Even the neuroconduction study is measuring hundreds of axons rather than the individual axon and the rate of firing of that axon.
But that is what you're doing when you're stimulating the surface. You're just sort of hitting it with a bomb.
So I don't know if they've taken a micro electrode, pipette, and put, an electrode into a single motor neuron. Probably have to determine what kind of rate of fire.
I think
I don't know much about
it's
this.
need a physiologist.
and, I mean, it's certainly possible to do that, but I don't know if they've ever done it.
Thanks everybody for your comments.